Okay, good afternoon and welcome to everybody joining us today. We're really thankful that you take some time to join us today for this topic that we're really excited to share with you today. Before we get started, I want to introduce myself. For those of you that don't know me, I am Barbara Campbell. I am the Executive Director of the Dalton Foundation, and the relink.org project is one that is near and dear to our heart and one that we have been supporting since 2017. We have a couple of our staff with us here today. We've got Rachel Sobitz here. She is new on our team. We're really thrilled to have her. She is our Community Engagement Director. Welcome, Rachel. And we also have Bill Pica with us. He is our excellent database coordinator and administrator. He's the one that keeps all the data going in relink.org. Rachel, if you can you show the relink.org slide real quick?
Sure.
I just want to do just a little introduction to relink.org for just a second for those of you that don't know. We are an online platform of addiction recovery, re-entry, human trafficking, and basic needs resources for the state of Ohio. We've got well over 10,000 resources on there covering all 88 counties, and this is free. I mean, we want it to be free for everyone. We want everyone to find what they're needing quickly. And we want to have the resources available across the entire continuum of care from detox all the way through until finding employment. So we try to put everything in one place. And another one of our core pillars is education. And that's why we do these collaborative webinars. We like to bring people together, share best practices, hear what's going on around the state. And so that's why we're here today. I'm really excited to have our two speakers with us today. I think you're in for a real treat. The Brightview system, Rachel, if you want to put their slide up for a second. I think many are familiar with Brightview from around the state. They have many locations. I apologize, I don't have the number with me right now, but all over the state providing treatment services for years here in Ohio. And we thank you, Dr. Patel, for being with us today. And then we also have Dr. Bryan Borland with us today from Basecamp Recovery in the Columbus area. We're working on a project with them on the effects of the opioid epidemic on families and some training on that. And it's been a pleasure to work with them on that project. And that is one of our announcements, relink.org coming soon, probably by May 1st, should have family resources on our site as well. We're excited about that addition as well. There we go. Thank you, Rachel. That's coming soon for us. So again, thank you everybody for being here. Hope that gave everybody a few more minutes to join in. And I also wanted to introduce from Brightview, this wouldn't happen without Brittany Wallace. So Brittany's here with us too. She's the one that helped us coordinate this, and we're really thankful for her support and effort in this. But without further ado, I want to turn it over to Dr. Parag Patel with Brightview to share with us on navigating opioid recovery during pregnancy.
Thank you. Thank you very much. You can go to the next slide. So appreciate the introduction, appreciate the opportunity to meet with everyone. Most of us, it's the afternoon. Anyone that's coming from West Coast, good morning as well. So my name is Parag Patel. I'm the Vice President of Medical Service Development and Compliance at Brightview. I'm also the Senior Medical Director. My background is in obstetrics and gynecology and also double board in addiction medicine. Started with Brightview about 6 months after they first saw their first patient, which was about 7 years ago. And we have about 37 sites throughout Ohio currently, almost 70 now through 7 different states. Have a lot of experience that we have been able to obtain throughout our experiences and growth, both from the acquisition of other organizations as well as our own internal growth. If you can go back a slide, actually. A couple of the key points that we want to address and talk about are going to be what is Brightview, gave you that real quick, NAS, SEF-MAT drugs, breaking the stigma of NAS and mothers with SUD, support for a healthy baby and mother during pregnancy and postpartum, significance of giving support to the pregnant woman in treatment, managing postpartum depression, anxiety, how to access Brightview. So at our core, what Brightview is a multifunctional specialty group that deals in addiction treatment, We are more than just medication. We do the whole biopsychosocial model, and that does really apply to our pregnant patients that we see here at our facilities and throughout the state. We want to be, actually, if you can go back a second.
Oh, sorry.
Okay.
Oh,
Well, that's all right. So at our core, we do have this
it's
biopsychosocial
not
model.
wanting to cooperate. Yeah.
Yeah, you're fine.
There
We
we
have a
go.
harm reduction model that means that we are not necessarily going to allow anyone to do what they want to do, but we're going to want to make sure that they're doing better yesterday than they were today, doing better today than they were yesterday. So having that understanding that that might not be what all of our communities, especially throughout Ohio, are used to. That's why we have to make sure that we have a commitment to the community members, make sure that we understand what the needs in that community are to be able to help make sure that we're on the same page. And if not, have a conversation around it. We're not always going to agree on how we're going to deal with our patients, but we should agree that we want to have a positive outcome for that person and the infant, the fetus, the baby. And then we want to make sure that we're allowing ease of access to our treatment facility, our patients. Not all facilities or clinics take pregnant patients. We do. We have no waiting list. Brittany may talk about that here in a little bit. We can go to the next slide, please. So neonatal abstinence syndrome, that's actually two. NAS, and what it is and what it causes. It's neonatal abstinence syndrome is the drug withdrawal syndrome that's experienced shortly after birth. It happens due to a discontinuation of meds in an abrupt manner. It's not just opioids, it can be other medications. Most notably, we have seen SSRIs. Zoloft had a little run-in back in 2015 with a couple of papers that came out that just shows us that this thing that's called NAS is not just for our what we might consider illicit opiate use or drug use. In that spectrum, we also have fetal alcohol syndrome disorders as well. Specifically for opioids, we have NOWS or neonatal opioid withdrawal syndrome. Important thing to understand here is that 50% of patients, fetuses, babies that have come in contact with any opioid throughout pregnancy can develop this. You'll have many stories of moms that'll come back and say, hey, yeah, I did this thing 3 pregnancies in a row, nothing happened, and I'm good. Well, it just so happened they flipped the coin 3 times and it came up heads every time, right? So it's a 50% chance any opioid or other drug utilization during the pregnancy process might lead to NAS or neonatal abstinence syndrome. You can go to the next slide. We're talking on this most specific about opioid use disorder. So medication-assisted treatment or medications for opioid use disorder are key in helping that patient feel better. So most patients don't come out, think to themselves, hey, I'm going to use today. They're going to wake up thinking that I don't feel good. I want to feel better. Now, this is a person that has this opioid dependence. It's physical withdrawal symptoms that are typically happening with our patients. In pregnancy, that kind of revs up a little bit because of the hepatic changes that are happening. The liver is metabolizing medicines, drugs a little bit more quickly. You have patients that have more adipose or fat tissue that is then seeping that drug back into the system at inopportune times. You also have we also have an understanding that the medications that we would normally use in opioid use disorder are 3 FDA-approved ones: buprenorphine, methadone, and Vivitrol or naltrexone. With the most recent understandings of how these medications work in pregnancy and how they may or may not affect pregnant patients, the old adage that everyone had to go to a methadone clinic is no longer the case. Most patients should have buprenorphine by itself. It's still a thing, but we have learned that naloxone is okay, naltrexone is okay in pregnancy, especially when we're talking about the risks of continued utilization of the drug versus the decrease in the risks of that utilization or use. There's a mother study that was put out in 2015, 2018. Dr. Borland can help me with that. Sorry, I don't have that off the top of my head, but mother study was done where they compared, the researchers compared the use of buprenorphine and methadone for our patients that had neonatal abstinence syndrome that was related to opioids, found that the buprenorphine cohort did a little bit better in the amount of time that they're spending in the NICU nursery. There's also more studies that are being done with morphine substitution as well. So luckily we have a great hospital system here in Ohio. Children's has a couple key, I think 3 key facilities now at this point that are doing some of these research studies. So really fun and interesting to work with them. Briefly talking about those medications for opioid use disorder, you have the full agonist, or the one that's going to mimic opioids the most, which is going to be methadone. Has been more of a standard. It has just a lot more data behind it, over 70 years of utilization. Because of pregnancies, a lot of researchers have a difficult time, and rightfully so, to do any true blinded case control studies to these different medications. But by case review, by observational review, we do see that buprenorphine and buprenorphine combination product with naltrexone is as effective in our key component of reducing the utilization of opioid during the pregnant period. Next. The unfortunate thing, the part about stigma, is that most patients aren't acknowledging that they have this issue. A lot of my OB colleagues don't think that it's an issue because we don't look for it. And then patient shows up at the hospital. They might be in a hospital system that is a reporting hospital that's required to report, and all of a sudden things start hitting the wall, hitting the fan that could have been avoided or potentially tampered down had we just had the discussion prior. So one of the things that we do want to make sure is that we take these stats with a little bit of a grain of salt, only because this was back from 2019. CDC put this out that asked 21,000 people, 21,000 people responded, females that were pregnant, and understand that only about 20% of those pregnant moms actually acknowledge the fact that they do have some kind of use disorder or use, even as it were. So when we asked about that, we see that 7% of women that were surveyed said that they did use some kind of opioid pain reliever during their pregnancy. 21% of those said that they had misused them, and 27% said that they were trying to cut down or stop using. The data that this came from didn't really give us the information on what that follow-up was. Next slide, which goes into what we can do to break the stigma of neonatal abstinence syndrome and the use of substances in pregnancy. We can ask the question. So ESPER, screening, brief intervention, referral to treatment, having something out in the lobby that might just say, hey, do you or someone that you know have a problem or an issue? How can you get help? It doesn't have to be something that even the OB needs to deal with or the MP, the nurse midwife, has to deal with. It's just a way to start communicating and then referring as would be appropriate. Anyone can be referred. It's just a matter of how you address that with your patient, which is the difficult part. Because again, I'm an OB, I did it for a long time. I don't want to upset my patients. I don't want my patients to think that I'm judging them. I don't want them to think this, that, the other. Urine toxicology testing in itself is not a good enough method to be able to identify patients that are at a higher risk. Utilizing utilizing the tools that we have, both in a primary care setting, in an adolescent care setting, in our OB setting, is going to be the most effective for us to be able to help with that. Patients that have babies that have NAS, it's treatable. It's something that's five days or so of medication treatment, not even needing medication in all circumstances. There's more recent data over the last couple of years that says, hey, maybe we're over calling NAS. Maybe the Finnegan score that we were utilizing isn't as good as we thought it was. Great for the time, but we've made progress. We understand a little bit better how nursing, skin-to-skin contact, swaddling, cooling can cause some of those numbers to come down that might be artificially increased based on observational bias. So another stigma point is even in the hospitals, we sometimes hear staff say, yeah, poor baby Johnny is addicted. When babies aren't addicted to medication when they are born, they are going through this withdrawal. symptomology, which is a physical dependence that we spoke to earlier, that can be pretty easily controlled. Were we able to find it in time? So often we'll have patients stay in the hospital for about 3 days, especially for those that we know that had an issue. And that goes back to the whole, let's make sure that we're finding those patients ahead of time, because sometimes being able to help them is timing is really key and crucial. Next slide, please. Yep, just talked through this already a little bit about non-pharmacological and treatment options for our NAS patients. So happy to take any questions about this. Don't really go into this too much, but our nursing team and colleagues throughout the states have done just a phenomenal job of being able to, those that are of more of an understanding of what this is. So again, the on-site nursing staff are the ones that said, hey, maybe Finnegan isn't the greatest thing, so maybe we can identify another option. So utilizing our whole treatment team is very key in this. Next, please. So what are we going to do? So how are we going to help try to make sure that the patient that either thinks that they have a problem, the provider thinks that they may have a problem, gets that person over to referral? So asking some pretty key questions to your referral partners. Do you have a pregnancy program? Pregnancy program doesn't mean I see a pregnant patient and mark yes on their talks when they say, am I pregnant or not, right? So an all-inclusive counseling component, so the biopsychosocial model, where we have specific or set up specific interaction with pregnant patients in various stages of their pregnancy, whether it's they just found out they were pregnant 8 to 13 weeks, or those that delivered within the last year. Understanding how those interactions are going to be important is important for us to know that we can't have necessarily a set curriculum. It's great to have one, but making sure that we allow plenty of time for opportunity for questions to be answered. Bring our community partners in. Having CPS come in. CPS isn't the big and bad in most places, especially here in Ohio now. CPS understands that this is starting to understand more that this isn't a choice. Addiction is a disease. It's a chronic disease of the brain that just makes us do things that we normally wouldn't do. Who would think in their right mind, yes, I'm going to do this thing that's potentially going to harm this thing that's in my uterus, right? It's not a rational thought process, but we're looking at a disease of the brain that doesn't allow us to think rationally. And those outside entities need to help us with that. And CPS, when I started this 7 years ago with these guys, it was an uphill battle. But if anyone from CPS is on, thank you for the collaborative efforts that we've had throughout the state that I've been a part of. So I appreciate that. Respecting mom's autonomy, making sure that she understands what's going on, right? She has the right to say, yeah, no, I don't want you to tell my OB anything. 42 CFR is a very strict way for patient confidentiality to be enforced, but it's for us to be able to say, let's make sure that we understand why you don't want us to tell them. Oftentimes there's a misperception or a misunderstanding of how that information might cause them harm in some way. And then we go back to the whole communication process that, yes, having this information out ahead of time gives us some way of being able to help minimize any possible problems that might come in the future. The effective communication. I want to make sure that I know who my patient's OB is, where they're going to be delivering, and any aftercare issues that there might be. Are they going to give this patient up for adoption, or this baby up for adoption? Because we need to make sure that adoption agency understands what's going on. We need to make sure that the social worker on site knows what's going on. We need to make sure that if the mom's significant other isn't welcome, that we know this kind of information as well. So that continued communication throughout the whole system is really, really important. And then just briefly on why toxicology screening on its own is not very good. You only are testing for 12 generic groups of medications or drugs, of which there's maybe between 10 and 20 analytes inside that. So it's just not a good test. It's a good start, but additional data points are really going to be important. And the best way is just to ask the question. A little bit uncomfortable, absolutely, but asking that, putting that as part of your intake, and then maybe a couple times throughout your pregnancy visits with that patient's really going to be helpful. Next slide, please. touched on a couple of these barriers already. Most patients in Ohio, if they're pregnant, are going to be able to be eligible for Medicaid. Let's make sure that if there is a referral that's made, that we get into some kind of treatment. Some treatment is better than no treatment. Ignoring the problem is the worst, right? So, hey, let's start this process. We at Brightview, we take everyone, regardless of insurance status. We will help patients get into Medicaid. Hospitals have a great system in place because hospitals are the ones that are going to be doing the deliveries, and the hospitals want to make sure they get paid. So they're going to make sure that they get their any possible resources available for that delivery aspect. We don't have a lot of beds. This whole idea of everyone needs a bed is a misnomer. People need treatment. So where on the continuum are you able to get someone into should be where you start. So we identify someone that has an issue. They might qualify for residential based on ASAM criteria. No residential available doesn't mean you shouldn't put them somewhere, right? So we here at our facility at Brightview and other facilities throughout the state, we'll take those patients as a stopgap. We'll start that process with that patient. We want to work with our community partners. So if there's a residential service area that doesn't allow people to bring buprenorphine products on site, but they have to go get methadone at a facility, let's make sure that we have that communication so we can plan for that. We have the ability, especially through COVID, to be able to deliver methadone to some patients if need be. So all kinds of options that are available that might not be known to everyone, but that need to be made sure that those things get followed up on. In yellow, I mean, one of the biggest barriers is, again, what we talked about. Patients are just scared that if anyone finds out about this, I'm going to lose my baby as soon as they're delivered. Not necessarily realizing that most of Ohio, and someone can correct me, but I think most Ohio hospitals now are required reporters. So that would be one of those areas, again, where if we have the information ahead of time, we might have a little bit better chance to assist in those barrier interventions. And then just making sure that the patients and the moms know that they're allowed to ask whatever questions they want to ask. You know, there's no silly or dumb questions, even if they've done this 3 or 4 times already. And for the providers out here, it's okay to repeat the same stuff that we assume they would know. Just because what I told them might not have resonated the way that Dr. Borland said it, 3 weeks later. So having those conversations, even as repetitive as it may sound, how many times do you have to tell someone to stop smoking or ask them if they want to stop smoking before they say, sure, I'll take the patches that you were talking about. So it's at least 7. So, until it clicks. So making sure that we're having those conversations. We'll go on the next page. Coexisting comorbidities, so anxiety and depression, especially postpartum depression. What we find is that patients that have a prior history of use disorder are almost 50% more likely to develop a postpartum depression. Important again for us to make sure that we're following up with our patients on a regular basis, that they're going to their postnatal care appointments. And if they're not, we as those that are in the substance use facility, substance use disorder realm, need to make sure that we're providing that whole holistic approach of care. So not just giving them their buprenorphine, increasing them post-delivery and saying, yeah, see you back in a month for your next fill. It's having those conversations. How are you doing? Who's helping you at home? Is there enough support at home? Are you getting enough time for self-care? How is your medication? Do you think you're getting too much? Do you think you're getting too little? Having those conversations is really going to help that person feel like they're allowed to ask the questions. How often do we hear about patients going in an ER, coming back out and saying, yeah, they looked at me cross-eyed because all they thought I wanted was drugs. So we're very proactive in that. If you don't think you're getting enough medication, I want to hear about it. I'm not giving them a green light to say that, hey, yeah, give me more meds. I'm just saying, let's talk about it, because what you tell me may or may not change the treatment plan that we're going to go forth with. How do we deal with this postpartum depression patients? Let's make sure that we understand that could increase their use disorder. So some patients that fall off are going to fall off because we don't diagnose or at least help to address some of that depression and anxiety. Let's have the conversation as to whether medication pharmacological therapy for an acute episode for 6 weeks or so might be beneficial. Not going to do a lot of good as far as giving them the medication half-life or stabilization of the meds that they need, but it's a start that we can at least have that conversation initially, especially someone that's acutely ill. And then utilizing our psychiatric colleagues for anyone that does have that next level of hallucinations or delusions. Next page. So just as far as Brightview goes, it's a little plug and then pass it over to Dr. Borland. We are able to take referrals 24 hours a day, 7 days a week. We do it either online or through a phone call. We have someone that does manage our phone lines. All of our sites have some semblance of a pregnancy program. Not all of our sites are manned to the point of being able to do it on site. We have telehealth services available that are allowing us to be able to do group visits with our pregnancy patients. Happens usually at Tuesday at 10 o'clock. When we talk about those patients that need help right now, we have walk-ins every day except for Saturday. Patients are able to be seen up until about 3 o'clock, and we hope give the whole continuity of care. Not what this talk is about, but happy to get into that a little bit more if there's any questions in the future. So just want to say thank you very much. And we pass it over to Dr. Borland.
Thank you so much, Dr. Patel. I really appreciate that. And I loved your presentation, and I appreciate all the comments you made about the communication. I think I hear that a lot with talking to Dr. Borland, and I think that's just so important in dealing with, in helping and supporting. And I really appreciate all that you guys are doing in that realm. For those of you, I typed it in the chat, but if you can type up some questions in the chat, we will go back and answer them after Dr. Borland shares a little bit about addressing the adolescent population. And when it comes to questions, I'll speak for Dr. Borland. I know he loves answering questions, and I'm going to put Dr. Patel on the spot. He loves answering questions too. Any kind of question is open to ask. It does not have to be related to pregnancy or adolescence that we're talking about here. We just really want to create this opportunity. If you have any questions or you're struggling with anything personally or family-wise, to have this opportunity to ask a medical professional. So go ahead and type those in, and Dr. Borland, I'll turn it over to you.
Awesome. Thank you guys for joining us again for this webinar. I'm excited to talk about some adolescent features in substance use disorder. The first point that I want to really hit on is that I think we're really missing the boat on education and prevention. And for instance, some of the data that we have really shows that with the screen that I'm sharing right here, that the earlier a person uses or experiences the use of drugs or alcohol, in this one particularly alcohol, the greater the significance that they will be diagnosed with a substance use disorder later on in their life. And so I feel like this data is easy enough to understand, especially for high school students, that, hey, look, if you hold off in using, if you remain abstinent, if you don't use early on, your chances of being diagnosed with a substance use disorder later in life significantly decline, which we can see people who use at 11 to 12 here, people who use less than 11, 13 to 14, 15 to 16, 17 to 18, and greater than 19, these numbers are significantly different and have a different course based on the age at which a person begins to use. Another graph that sort of shows this as well. This is from a JAMA study, and this shows a combination of two different factors that, number one, family history, mom, dad, sisters, brothers have alcoholism or drug addiction in the family. Combined with age at which a person first uses. This study is also dealing with alcoholism, so that if you're 13 and you have a genetic predisposition, you have almost a 60% chance of being diagnosed with a substance use disorder later in your life if you begin using at 13.
Hey, Dr. Borland, I'm sorry to interrupt, but I don't think your second picture showed up on our end. Or maybe that's just me, I'm sorry, but
Oh, I will get it.
I'm sorry.
There we go.
I hope I'm not the only one. I'm sorry to interrupt you.
How's that?
Yes.
Perfect. All right. So the second one here, as we were mentioning, this one combines two different factors, one being still age at which the person begins to use alcohol, and then if they have a family history that's positive or a family history that's negative for substance use disorder. So those with a positive family history who begin using at 13 have almost a 60% chance of being diagnosed with substance use disorder later in life. Compare that to family history negative, also use at 13, around 28%. And so these concepts are not necessarily difficult concepts, especially for a high school student to understand. I can't say that in my own experience, knowing this information would have necessarily changed my outcome later in life, but it certainly is something that when we're dealing with an opioid epidemic, that this is something that should definitely be out there in health classes and have more education based on these sort of ideas. Secondly, Dr. Patel hit on it, but it's another thing that we talk about is stigma. It's very easy to want to deflect from the actual cause of a person's use of drugs or alcohol. It's when viewed as a moral failing that I don't want little Johnny to be labeled as a drug addict. I'm just going to say he's going through a phase, or that he's going through a breakup, and because of that, he's using drugs and alcohol. And some of that stigma is that this is a medical diagnosis, and just like being diagnosed with diabetes or COPD or asthma, it's a medical diagnosis. And when we frame it in that mindset, the medical diagnosis automatically sort of draws you into the fact that there's going to be treatment that's necessary in order to assist with this substance use disorder for them throughout their life. Unfortunately, right now, adolescents 12 and older, there's only 11% that receive treatment that have a substance use disorder. And between the years of 12 and 17, only 6% receive treatment for their substance use disorder. So these levels of treatment are significantly low, especially compared to other diseases, other chronic diseases that mimic this. And so one of the other topics, probably my last topic here that I'm going to hit on, is that in viewing all of this and bringing it all together, the idea of marijuana has significantly changed over the past 5 to 10 years. In 2000, there was a study that was done, and 58.3% of high school students thought that regular marijuana use was harmful. In 2017, that same study was done again, and it was now 31.1% that believe that regular use of marijuana is harmful. So that's down 27.2%. And knowing some of this information that we talked about here, that age of first use of whether it's alcohol, marijuana, or other drugs significantly impacts the likelihood that someone will be diagnosed later in life. And so therefore, there needs to be some further education on marijuana and its link to substance use disorder, as well as to the negative health effects of marijuana. So I'm going to stop there, and going to give an opportunity for people to ask questions. And thanks again for being here with us.
All right, thank you so much. Now, someone had their hand up earlier, and I will say now that both Dr. Patel and Dr. Borland have had a chance to share, if you do want to raise your hand, we can allow you to speak. If you'd like to type the questions in the chat, we certainly welcome those. If I can start by asking a question of Dr. Patel, I think, again, you're dealing with the special population of OBGYN, it's got to be so challenging. Is there a particular story that you could share with us, maybe a success story or something, maybe not a success story, but something that you really learned in dealing with this pregnant population that has affected the way you practice?
Yeah, thanks for the question. So it's more of an anecdote. an area of just so much shame for a lot of moms that it really opened up some eyes for me. So I practiced OB for 10 years before I started doing addiction medicine. Just had no idea about the angst, the anguish that moms deal with, and just being able to open up and being able to be forthcoming, because not only moms, most patients in general, but moms more specific, because they're taking care of at least one other, talking about how they just feel so bad, and I don't want to do this anymore, and come in tearful. And for the most part, right, there's all kinds of spectrum, but those are the ones that hit the home the most for me, is being able to say, yeah, we understand. Even if you were to have a relapse, even if you were to have an issue, we want to see you back. This is a chronic relapsing disease. That's the way it's been defined. We understand where you're coming from, and hopefully you don't have to beat yourself up. Great that you look in the mirror. Great that you're here asking for help, taking the next step. Let's do the next right thing together.
Yeah, this idea of the stigma, and I know the state of Ohio is doing a really good job, at least from the outside looking in, at trying to create awareness of the stigma, but really understanding, like you said, what people are going through, and to have someone to go to that understands. I know I hear that a lot from you, Dr. Borland, too, that really can understand and relate. It's huge. It's huge. Dr. Borland, do you have a story or example to share from your practice?
I don't know if typically we do not see adolescents here at Basecamp, but I will tell you sort of one of the conundrums always that comes up is that when we're evaluating a person for medication-assisted therapy, there is the literature is really sort of based upon for methadone patients that are 18 years and older, and then sort of for buprenorphine patients that are 16 years and older. We just don't have a ton of literature that supports the use of MAT earlier in an adolescent's life. I think that at some point in time, we have to really consider the risk versus benefit in those cases, whereas we try and view opioid use disorder as an emergency. 24 hours a day, this is an emergency, especially with fentanyl showing up in all kinds of different drugs right now, that really substance use disorder is an absolute life-threatening emergency. And so that sort of makes that decision very complex, because you're saying it's not necessarily FDA approved, but at the same time, I believe that the risk versus benefit, it justifies why we would use this particular, whether it be a buprenorphine product or methadone product. So some of that is very difficult in the adolescent world to navigate those waters.
Yeah, thank you. All those things that you remind me, just never think of in these special populations, all those extra challenges. Monica had a question for Dr. Patel that I will read out. She works with Metro Health as their project coordinator for the Mom's House. And she was wondering, Dr. Patel, does your Parma location offer transportation for IOP? And are there any childcare options that you know of?
So Brightview doesn't have its own fleet, as it were, of vehicles, but we do work with our partners. I think that we still are working with Lyft, either Lyft or Ride, one of the organizations to assist with those, especially with their induction periods. In terms of, what was the second part?
The second part, I'm sorry.
Did you say there was two questions?
Yeah, there was a second one about childcare options.
Oh.
Do you know or refer out for any of those?
Yeah, we don't in-house necessarily, but again, our social services is regionally based. So those in the area of Parma proper would be able to get more information on what teams were out there, what groups were out there, what organizations were out there to be able to help provide us support, whether it be supplies, child supplies, or housing, or just babysitting needs. So I would defer back to Brittany to get that information for the Parma team together for you guys.
Okay, we can connect Brittany, and we can make sure we share that information. We will send a follow-up email to everybody who joined, and even those that registered that couldn't join in, that will have the recording of this, and then we'll answer some of these questions and do some connecting as well. And we had another question come in. I believe this is for you as well, Dr. Patel. What is the length of time you would prescribe Suboxone or methadone?
as long as they need it. So, the beauty of this medication is that the beauty of both those medications and naltrexone or Vivitrol is that it's saving someone's life, right? One way or another, it's saving their life. So I'm not going to stop your insulin because someone looks at me and says they've been on it long enough, but have they? This isn't like diabetes where if you cheat and have a cupcake, okay, maybe 3 years or 3 months from now, your A1C might go up a little bit. If you cheat and you get something that's laced fentanyl that you thought was a Percocet pill, you're going to die. So in that circumstance and sense, we're a little bit contrary to the least amount of medication that works concept. We oversaturate with these medications. We want to make sure that those cravings and urges centers are bathed with as much medication as possible, that we're protecting and supporting. So not trying to be flippant in any way, but we don't do, let me back up a little bit. In other states, there was specific rules that said every X amount of time you had to initiate a taper. Those rules are few and far between now. The conversations now are, let's have a conversation about taper. Let's have a conversation about, are you on the most effective, are you on the least effective dose? Which happy to have after about 18 months or so of good recovery, good sobriety, helping us know that, there's more accountability that the patient's holding to themselves. I'm not going to hold them accountable. Patients need to hold themselves accountable to themselves to be able to show that they're doing good in their recovery and their sobriety. Then we can talk about reduction of that medication. Yeah, good question.
Yeah, Dr. Bourne, did you want to add to that? I know that we've had other discussions, and I know you've had just great thoughts about people on the treatments.
Absolutely. I couldn't agree. I think Dr. Patel has been watching my lectures because he stated all of my normal points. It's really, what is success? And success is the ability for a person to bring happiness back into their life, to enjoy their family again, to work, to pay taxes. And so if that's what's happening and they're using a buprenorphine or methadone in order to make that happen, I'm going to be the last person that says, hey, let's roll the dice here with your life and possibly risk, undoing all of this progress that you've made. We don't force diabetics off their insulin. We don't force people on their antidepressants to be like, wow, you should really come off that antidepressant now, or else you're a weak person. We don't force any other chronic disease states to come off of their medication. And so I completely agree that it's a very individualized process. And it comes down to, do you have a supportive recovery program that if we remove the medication, will be able to pick up for the area of your recovery program that disappears from that medication? If you have a robust recovery program, then it's something we'll definitely consider. And have that discussion.
Yeah, thank you both. I think it's just interesting doing this job for like the past 4.5 years, how the answer to that question, I've heard the answer to that question change. And so I really am, that's very encouraging to just hear that. So thank you both. I appreciate that. We have another question here. What is the general approach of CPS in Ohio towards moms with SUD, specifically as it relates to custody? Dr. Patel, you may know that.
Yeah, in general, it's much different. I won't say better. I'm saying better, but I won't say it because we're recording. But it's different now. It's a lot more positive. It is more of understanding. It's more of this is a disease. Let's see what we can do about this. Now, that's not everywhere. It's not. It's not agent specific necessarily, but it is more region specific still. For us to be able to say that once we get into the system or are observed through the system, we want to have a safety plan. That's a great idea, right? I mean, we want to be able to say, these are the things that we expect to have happen. These are the amounts of times we're going to check in because we want to help make sure that the patient is holding themselves accountable to themselves and to their baby. We want to make sure that we have the ability for them not to fall through the cracks. They're coming in every week for the most part. And now all of a sudden they're free to do what they want to do with their schedule. Yet they have this brand new infant that's keeping them up all night. And they have anxiety, they have stress, they have issues. So CPS's involvement in the community has been a positive. It really has. That's been our experience.
Yeah, that's another great trend that I think a few years ago, the question might have been answered a little different or avoided, but I think that's really great. I think that's great, like a partnership. That's wonderful. Monica had a follow-up question, Dr. Patel, and this may be one we connect Brittany with too, but when working with Lyft or one of the rideshare programs, does Brightview offer vouchers for clients?
Yeah, I'm going to defer that back to, I haven't been in the field for some time. Apologies, I don't have the direct answer to that, but there was a program in place with COVID. I don't know where that is currently. So, but we, at least for the first 2 visits for induction, getting them into the system, and then the community is pretty good about pitching it as well.
And I see Brittany answered it. You can tell I'm scrolling the questions one at a time. So I apologize, Brittany, you answered a little bit about that you do provide transportation for the first 2 visits. It sounds like round trip. To
Yes,
and from
and one of the nice things about our program too is that we'll actually transport them within 20 miles of their home. So that might reach multiple Brightview sites, but as long as it's within 20 miles, we will transport.
Okay, great. Thank you. And then we had, this one is for you, Dr. Borland, about adolescence, Megan's interested in getting research going for adolescents. It sounds like, Megan, you have some experience with this personally, and just trying to get this. I think the way you started, I think was perfect, Dr. Bryan. Like, there's evidence that shows the earlier you start, the harder this is going to be. How do we get this information out there into more schools, into more prevention programming? Like you said, right, Dr. Borland, you may or may not have listened, but hey, at least give these teenagers the opportunity to listen before they start using, right? So
Yeah.
Is there any research that you know going on with that?
To be honest, I don't know of a ton of larger studies that are being done. I know that there are some smaller studies that are out there in the academic world. It's very, very difficult to study a medication, especially in adolescents or pregnant patients, because of the risks that come with that. But again, I really do believe that as these drugs become more laced with fentanyl and the exposure rates become lower, that I think we're going to really have to weigh that idea of we're probably going to have to be more aggressive about using MAT earlier in the substance use disorder life cycle, because we know that earlier identification, earlier treatment, we're going to prevent that patient from having a lot of consequences, and we're going to make this disease much more treatable. So I don't know of a ton of research, I'm sorry, or ongoing research, I'm sorry about that, but that's my thoughts on it briefly.
Yeah, and one thing I've heard you say, Dr. Borland, a lot too, that I think is really helpful too, is that you've observed in your practice that a lot of times when you see your clients coming to you, if you were going to rate them on their disease of a 1 to a 10 as to where they are in the disease, they're coming to you at an 8, 9, 10, or even 10 plus, and how much better it would be, how easier it would be, more likely for success to treat if you could catch them more at a 1 or 2 or 3 in the process. And I think a lot of that speaks to the prevention and awareness programming as well.
Yes.
Yeah. So if there's any more questions, there's one more question I'm going to read out, but then after that, if there's any more, please let us know. I think I know the answer to this one, but it's coming in. Does Brightview or Basecamp see pregnant patients? The comment, Ohio Health has a grant allowing substance use navigators in the emergency departments. And part of that includes pregnant women.
Yeah, we do. We do at all of our sites. I have 4 OBs throughout Ohio that are double boarded in addiction and obstetrics. So yeah, would love to work with that person. Brittany can reach out and see how we can utilize that resource.
Yeah, it's very, very similar here. That we work very closely with the substance use disorder navigators here with Ohio Health, and we absolutely take pregnant patients. More than happy to keep that collaborative option open for Ohio Health with us.
All right, and Brittany, I think there's a follow-up question, Brittany, of what organization are you with? Brittany's with Brightview. And Brittany, I don't know if you want to share your email information for contact, otherwise we can connect. Okay.
Yep, I'll put it right in the chat for you.
There you go.
Thank
All
you.
right, there's that information. Okay, are there any other questions? I really appreciate all the questions that we did get. Anything not even related to the topics we talked about are also fine to ask. It's not every day that you have two wonderful physicians in front of you to ask questions. So if there are anything, please don't hesitate to ask.
I just wanted to mention, along with the SUD navigators with Ohio Health, I know that there are probably some people on who are involved in CPS as well as some of the drug courts. And I just wanted to really discuss how your organizations have come so far in the education about substance use disorder and the ability to manage patients in a collaborative method with treatment providers. And so it really does, it's a lot of work for you guys. These are challenging patients, but you put in a lot of work, and we really respect that and love the opportunity that we get to collaborate with you and work through this on an individual case-by-case basis. So thanks again for all the work that you do and just really looking out for these patients.
That's great. And one other thing I want to add, if there's no more questions, and we'll send this out in the follow-up email. We have been working with Basecamp on a project for family education. And again, it's around this idea both of stigma, educating families to help reduce stigma, but also supporting the families with the goal of trying to keep as many families, together and thriving versus just surviving as possible. And so we do have a little program. There's a little online training. If you've heard me say this before, one of the things I love about it is it's bite size. One of the challenges when you have a loved one struggling with substance use disorder is the stress, and we know that sitting down for a long education session might not be realistic, but the information is nonetheless really important to have, and having support is nonetheless important. So Dr. Borland and team there have put together some short little trainings to help support families, and we'll send out a link to that because we would love to encourage more and more people to one, take the trainings if they're helpful, but also just to look at them. They're 10 or 15 minutes each, and just offer some feedback as well. So for both reasons, we love for people to take those.
I put the link in the notes there.
Thank you.
It's beginyourclimb.com. You can go there, you make a profile, it's anonymous, there's no payment required. And then there's, I believe, 3 or 4 lectures on there. There's a pre-test and a post-test. And we've had some really, really good success with people enjoying the course. And we certainly welcome any feedback, because it's all about trying to make this process better and more easily utilized by those out there. So feel free to give us all the feedback you have.
Yeah, thank you. I will have to say, though, to credit to Brightview, Basecamp, all y'all, everyone working on it from the outside looking in. Again, the stigma that the things that we heard 4, 5, 6 years ago are different than what we're hearing now. So I think the education, it's helping. I mean, there's still a long way to go. I don't think we're done, but it's working and it's helping. And I think it's really helping save lives and also help those that are coping with it as well. So thank you guys for all that you're doing to be the voice of the advocate.
Yeah.
All right. Thank you again for being here. Thank you everybody for joining us.
Thank you.
Have a great rest of your day.
Bye.
Bye-bye.